We can definitely disagree. Just one person's opinion. Definitely. But there's so many things in general in prevention. I don't mean to offend. I think that in prevention in general, especially the things that we would agree to, because there's so much to do. Tobacco. Giving people education on tobacco prevention. Very basic stuff, right? So these are the things that we should be spending our money on instead of repeat cardiac tests when somebody already didn't want to go for another cardiac procedure. So I think that's what the goal is with accountable care organizations for people. Then there's electronic medical records. I think many of you have probably suffered that discussion at your facilities. Really controversial as well. A lot of money is being spent on EMR incentives, and I'm going to say this out loud, I'm not a firm believer that that's our solution. I can tell you one of the reasons we should do something organized as far as health records go, and that's because we shouldn't be wasting money on extra tests and we shouldn't be making large medical errors. I'm not positive it has to be a complicated electronic medical health record system to do that. But we do have to be able to track and have a better idea about population health, which is why it's been so frustrating to see governments all across the country decrease their budgets for public health services over the years. Those services were very important because it helped us to know where we should spend our monies, where we really have problems. And the current approach in 2012 to put all these incentives into electronic health records, my feeling is, again, just one person's opinion, is to throw a lasso around all the information in the country so that after this experiment with the Affordable Care Act, we can see maybe better how much money did we spend, where did we spend it, where do we still really have big health problems. In that way, I think it is good to know. But I'm not necessarily certain that we had to do a piecemeal electronic health record system. Frankly, if we were going to do it, it would have probably been better to do a very centralized single system that was maybe a little more basic, but literally give it away to everybody. Look at the essential health problems, pick them. For example, diabetes. 10% of our monies are spent on diabetes now, 10%, which in the United States, that's $300 billion a year. It approaches our defense budget. You subtract Afghanistan, which are not going to be in Afghanistan much longer. So $300 billion in diabetes care alone. We could have just tracked diabetes and hypertension and we would have been close to the mark. But instead we have, I don't know how many of you have looked at your systems lately, but it is complicated and it slows people down and people are actually less productive in their first year with electronic medical records. So it's a big challenge. Maybe it will pay dividends later. It's not for me to judge. I'm just saying that that's a big part of the 2012 part of the Affordable Care Act. Also in 2012, we had a big moment, of course, and that was the Supreme Court. So Supreme Court ruled 5-4, as you're all very aware, that the Affordable Care Act would stand. And everyone has a different opinion as to why 5 people ruled for it. In some cases, some of the more conservative justices ruled for it. One of the more liberal, Kennedy, I guess he's on the fence sometimes, justices ruled against. But again, difficult to know what's in people's minds, but it did survive. And then in the wake of the election, it is surviving. It's going forward. So that was, I think, the most significant moment for the Affordable Care Act. Had we had it shot down, we would have gone a totally new direction, and we would have pretty much put everything into the scrap heap that we've done the last couple of years, which at least would have been disappointing to me. I don't know about you. So now that brings us up to present, right? This is November 16th, 2012, and all of the new initiatives are beginning to roll out nationally. We're past the elections. Everyone's going to have to work on things together one way or another. So what's going to come in 2013 and 2014? Well, 2013 is kind of now getting serious. We tinkered around with the accountable care organizations, and we closed the donut hole, and we provided some preventive care, and so we started to do those things, started to build some more health centers. But now the big guns come out. In 2013, the federal government will begin to tell hospitals, hey, if your patients end up back in the hospital again, we're not reimbursing for it. Some of those rules are still, up in the air a little bit, but they're hardening quite quickly. I'm not an expert in this area, but I can tell you that I've had discussions with Art here and with Chuck, and they're very concerned. The challenge to keep people out of the hospital is not a simple one, and people all behave very differently. Some people rely on the hospital. Of course, we know that there should not be a situation where someone's going to the hospital 100 times a year. We have those people. Dr. Ireland will tell you he's got a patient that runs the medic. He's the medic guru here for us in the state, Jim Ireland, and he's got one patient that's gone, I think, 150 times by ambulance to the hospital in a year. I mean, they have alcohol problems, but it's a health problem, and it's just can't do that. I mean, that is an expensive cab to nowhere, basically. And so some of these things, of course, have to be kind of handled, which is good. So I'm glad the government's stepping in there. But, to tell you the truth, people are going to have relapses over their heart failure. I see people every single year come in right after Thanksgiving and right after Christmas dinner, because I'm always on call because I'm Jewish, right? So they put me on call for Christmas. And so I get Christmas. I'm free for Hanukkah if you guys want to party, but I am pretty much tied up on Easter and Christmas. And so those are the big salty meals, and people get readmitted. And what are you going to do? Tell people they can't have ham in Hawaii or Kahlua pork? That's just not happening, right? So there are going to be readmissions. And are you going to tell the whole hospital system that they can't take into account a cultural phenomenon and therefore not reimburse them and penalize them? So one size doesn't fit all, and I'm concerned about that. I'm sorry?
I just wondered, are you...
Yes. Yes.
And we're beginning to get more referrals for our elderly. Yeah. Well, the Big Island, they're short, but are there other resources that are available?
Yeah. So I'll restate the question because in case we don't have Mike. So the question is a very good one. It's so if you're on the Big Island, for instance, which would also apply to Kauai or Molokai even more seriously probably, what resources does one have to help with case management and readmission? It's very few and far between, I'll tell you. The resources are absolutely limited. My experience notwithstanding, I work only weekends because the rest of the time I'm here in the Senate, so no one is available on the weekends, ever. So I often have to admit patients for observations in the hospital, try to work up home care for Monday morning, even though I probably would like to send them home Sunday morning. So many things are just totally not available, and that's just an extreme version of the week where the better facilities do have more resources, but even North Hawaii Community Hospital is having challenges economically, and they've historically had more money. One of the things we passed at the legislature last year was we called the Hospital Sustainability Act, and what it did was it had the hospitals kind of tax themselves, and money went into a bank account, and then they matched federal dollars, and it came back to them. So they recouped an extra $50 million for the system. It was meant to do exactly what you say, which is to hire case managers, to hire home nurses, to hire specialists on education for like medication reconciliation, because almost none of the hospitals have much more than a decent checklist and a discharge plan. And then a lot of the people don't have primary care physicians. So they end up seeking their primary care in the emergency department, which is just not feasible. I mean, it's not sustainable. It doesn't work. You don't have the records unless you come to the same ER, and then I know you if you come on weekends again. I have this weekend crowd that I see real frequently, But they tend to be drug addicts and alcoholics, and we're just trying to help them get through the tough part of their life. It's not so many people with their kidney disease. Although I do have, for instance, another example is, again, speaks to your question. I have a couple people that end up in the ER with heart failure every Sunday night. Why? Because they are on dialysis, and the dialysis only goes Monday, Wednesday, Friday, and so they have that extra day. And, what are you going to do? It's an extra 24 hours of fluids that are building up. I mean, there are phenomena in the healthcare system which are very hard to fathom. And we need those case managers, and we need more outpatient care, and we need these solutions where people add extra hours. All of those things are meant, if President Obama were sitting here with Sebelius, I think they would say, yeah, that's what's in the bill. That's what some of this stuff is, the accountable care organizations and the patient-centered medical home and what have you. It's meant to hire those supportive teams. And if the system works right, and in some ways some things are working right. For instance, I can't even believe I'm going to do this, but I'm going to say something very, very positive about HMSA. We've often fought, but they've done a pretty darn good job setting up the patient-centered medical home project for primary care physicians. In fact, I really commend Mike Gold and Hilton Rathel and those guys. They thought it through very carefully, and they're putting a lot more money into primary care for primary care physicians, and that might not be a great comfort, say, to those who run hospitals, but the physicians that I work with, like when I'm working in the Hawaii IPA, where I spend some time, my primary care physicians are getting an average of $75,000. That's the mean, okay? $75,000 per year based on their medical homework. And they're able to, medical homework, not homework. And their home care nurses now are hireable. They're bringing students in to spend much more time explaining the basics of people's health problems and how they can keep themselves out of the hospital and so on. So it really helps the hospitals theoretically, because if the primary care people do things right, then you won't have those readmissions, which they can't get paid for or soon won't get paid for at the hospital level. And that's another example of what the Affordable Care Act is meant to be. And so if we nationally do good things to get more care into primary care, I think we're going to really see a much better healthcare system. So let's talk a little bit more about the specifics of 2013. This hospital readmission reform is significant, but another thing that's meant to happen now is that you've probably read that Medicaid reimbursements are going to improve in 2013 and 14. They're going to equalize Medicare and Medicaid reimbursements for a year or 2 years, and then we'll see what comes going forward. It's something that I can tell you Susie Chun Oakland and me to a lesser extent. She's much older than me and has been there much longer. You please do. Susie is a gem, of course, and we've wanted for years Medicaid to equal Medicare because we never wanted people to be discriminated against by providers. You know, why should anyone ever look askance at a person that's poor and not give them the first slot in their schedule if they have the most medical need in the schedule? So not many providers do that, but everyone was so overwhelmed because of the shortage of healthcare providers in our state that a lot of times it was more difficult to find a provider if you didn't have private insurance, if you were on Medicaid. And 275,000 people in our state have Medicaid coverage. Over half, I think I mentioned this earlier, on Big Island. Over half of the people that live on Big Island have Quest. And those physicians, a lot of times, were leaving Big Island because they couldn't pay their bills. They couldn't pay their loans back. It wasn't because they were greedy, believe me. I had a bunch of physician friends over there that were making $55,000 or less a year, and they still had to pay medical school loans, and they still had to pay rent, and they had a spouse who always worked, and it was just too challenging. And they had to pay for private school maybe if they didn't like the public school. It sometimes happened. So these challenges are there, and by improving the reimbursements on Medicaid, though it will be expensive for the country and for states, because states have to pay a significant share of Medicaid, it will simplify the system. Now, had I been writing the whole healthcare reform bill, I'll tell you frankly, I would have erred towards single payer. Just my general feeling, you're an anti-fluoride, pro-single payer. You're like my mom, okay? I like that. So what I say about single payer is that it would have had to be a uniquely American version. I mean, we know people have different expectations than friends of ours have in Britain or Sweden or Norway or China or Canada. Sorry, yes, our Canadian friends. So we have different expectations, but I did think that there was a significant possibility for us to go to a modified single-payer system where people could at least get primary care exclusive coverage. And I think that would have been an approach that would have stabilized the care base of primary caregivers. It's, of course, an incredibly large thing to flesh out, but it is one thing that probably could have been done. But this is not what we're here to talk about today. We're here to talk about what's really happening. And so I'll go back to my point, which is by increasing Medicaid reimbursements, the hope is that it'll be easier on primary care doctors to provide the care at their facilities to keep people out of the hospital.